Hi, my name is Juan Filipino, and I'll be talking about my TMJ closed mouth projection for the project. Okay, so I'll just demonstrate on myself how we would do it, okay? But I have my checklist right here so we can go over it. Okay, the first part is pathology of structure shown. Well, we would do the TMJ closed mouth, which means the condyle would be in the mandibular fossa, right? And for the upside, because you're kind of going like this. Okay, I'll explain later. Okay, the IR size and placement. We would do at least an 8 by 10 or 10 by 12, depending on the patient's size. Table bucky or vertical bucky. You can actually do it erect, the same way you would do it prone. You just got to make sure it's in a true lateral and their head is turned a little bit. It may be uncomfortable for the patient, so that's why you would set everything up first. AP or PA. So the textbook says you have to do it in a semi-prone, but you can do it in erect. If patient condition permits. Other optional, erect. Okay, body part touching. So we would use the MSP, and we would also, it says imaging plainness used. The IOML must be perpendicular to the IR. Surface landmarks used. Okay, so let's just say, if I'm gonna lay down, right? If I'm the patient, right? So if I tell them, okay, you're gonna prone, right? So just lay on your stomach, and then you're gonna turn your head like facing the wall. You gotta make sure that they're kind of obliqued a little bit, right? And then once you do that, they're obliqued, and then you'll have your central ray already, angled 25 to 30 degree Caudat, and then you would just, you could, like, once it's set up, move the table and stuff like that. And make sure, I'll tell you guys how to center. Okay, so central ray, where does it enter? So it enters, so you start from the EAM, right? So they're like this for the upside, right? So you would go 1/2 inch anterior and 2 inches superior, because if you feel your EAM and then you go up just a little bit, you'll feel like the little hole, and that's where you gotta center. It's like right there. Okay. You have to use 25 to 30 degree Caudat. You have to. Okay. SID is 40, because you wouldn't put in a 72 SID. That doesn't make sense. Collimation to where? Okay, so slightly above the EAM. So, but you have to include part of the skull, because that's basically, it's kind of like right here, right? So you got to include just a little bit. Just you can't just collimate too much to see the fossa. You know what I mean? You got to make sure there's some anatomy. You see the lateral margins, a little bit of the orbital ridges, stuff like that. Markers, recommended placement. So when the patient's like that, you would put the marker like over here. So you would be like near the skull, like it would be away from the anatomy. You don't want it in the anatomy. It's very important because you're trying to get a small structure. So, by you putting the wrong placement of the marker, you can get an anatomy, then you got to repeat the exposure, and then that's more radiation to the patient that we don't want. Stuff like that. Respiration. We would ask them to hold their breath. Why? Because their mouth is closed, and also they're laying down. So it's not a projection. Then we need them to breathe in, breathe out. But it's best if you hold their breath, because if you breathe in, you don't want the jaw or whatever moving, and just make sure they hold their breath. That's the most important thing. What is best demonstrated? Like I said before, the upside TMJ is shown. How to check for proper positioning. Now this is very important, because when you lay the patient down, right, you got to make sure for tilt and rotation of the head, right? Because they're like this, they're very uncomfortable, and if the patient's unstable, you got to make sure, I got to make sure, because everything is lined up for you already. Just got to make sure you position them correctly so you don't have to repeat. And sometimes it happens, you may cut anatomy or you may miss it, and that's why, from the first picture you take to fix your errors, as if when we become technologists, and it helps us, make sure that we actually get it the second time around, because we're, giving more radiation to the patient. Exposure criteria. There has to be no rotation. The collimation should not obscure anatomy. It cannot. Very important. And also, if you see the superimposed lateral margins. That is key. If you know what superimposed, you say, okay, you know the head is in a true oblique. You know, I know for a fact that I'm gonna get the anatomy. You're gonna get it. You have to get it. Okay. And it's also very important that you shield. Very important. Where you would shield, you can shield, you know, if they're prone, you could just shield, you know, like to the gonads. You shield to you shield to the gonads, or you can go like a little up for the lungs. If you get a bigger shield, you can try to get everything, and that's about it. So that is my projection, and have a good day.